Good afternoon. My name is Jo Thompson. I am a critical care research nurse, and I would like to talk to you today about the SCARF project. I have worked clinically as a nurse for 8 years, 5 of which were in intensive care critical care, and for the last 5 years I've worked in research. So we have been running SCARF, the project, for the last 15 months. It is part of the Edinburgh Critical Care Research Group and the University of Edinburgh. I'm going to share some key outcomes, how SCARF, the project, started, and what the project is and what our plans are going forward. So some key outcomes before we start about the project. Provisional reports from the project, which we have ran for almost 1 year, show that we have reduced readmission rates from intensive care back into the hospital by 10%. We have found that our assessment tool is finding the patients who are most at risk for readmission back into hospital. And we have established really good communication lines with the integrated joint board hubs within Edinburgh to improve communication outcomes for our patients. The SCARF project is putting into practice some research which was found by the profile study, Preventing Early Unplanned Hospital Admissions Following Critical Illness. And the research team was by Dr. Naz Lone. And what we found, some of the findings from this were that there was 140,000 patients admitted into UK intensive care units each year. And in Scotland, that meant that there were 30,000 patients admitted to intensive cares within Scotland. And out of that 30,000, 70% survived, creating a cost of nearly £50,000 per patient per year. And as part of this research study, they found that within 90 days, 25% of these patients were readmitted back into hospital, not intensive care, but back into hospital. And within 6 months, 40% of patients were readmitted. Another part of the findings of the profile study was PICS, which is post-intensive care syndrome. And this is a gathering of symptoms that a patient who survives intensive care might experience. And they categorized them into 4 main groups of symptoms. Psychological symptoms, which was anxiety, depression, and PTSD. Some physical symptoms were muscle wasting, fatigue, weight loss, joint pain, stiffness, and impaired mobility. There was cognitive symptoms of amnesia, delirium, cognitive impairment, and social symptoms. Many people returned to work late. There was money concerns, reduced social participation, health and well-being of carers was an issue, as well as relationship strain. Surviving intensive care is no small accomplishment. It has massive consequences for patients and for family members. And actually in America, they have PICS-F, which is post-intensive care syndrome family, because a lot of carers and family members experience social disruption and depression as a result of their loved one having been in intensive care. So we see that there are massive factors that are associated to unplanned readmissions. And part of the profile research discovered that there was 10 main factors that contributed to a readmission of a complex intensive care patient. And there were patient-level issues and system-level issues. And so we have on patient-level issues, we had multimorbidity and polypharmacy, psychological problems and drug dependency, fragile social support, problems with specialist equipment at home, user-friendliness related to that, and poor mobility. And then the system-level issues was preparation for hospital discharge, communication or lack of between acute and community care, psychological support, medication support, and goal setting. So these were 10 main risk factors that they found from survivors of intensive care who were readmitted. And what they discovered was the more of these issues that each patient had, the higher the risk of the patient being readmitted back into hospital. Some readmissions are avoidable and some are unavoidable. And our goal was to try and find the avoidable readmissions and prevent them. So some examples from the profile research of potentially avoidable readmissions were drug-related. Medication errors happening in polypharmacy patients. And what we discovered was that patients who were discharged into hospital, who had polypharmacy issues, maybe had medications changed, but their pharmacist wasn't updated of these. And so old discharge scripts were given, and the patient was then given the wrong medication and was readmitted back into hospital with more complex health issues. We found mobility was an issue with falls at home, and mobility aids weren't always delivered in time for the patient being discharged, and they maybe had to wait a week or 2 weeks, but within that time they maybe fell or suffered injury which was preventable. Carer support was another area. Sometimes a carer may have been absent due to work or holiday or unforeseen circumstances, and this precipitated general collapse, possibly not eating properly, not medicating properly, whereas a simple package of care could have prevented another readmission. And medical support, not enough support being given for medical care. We had issues of nephrostomy bags being blocked or Hickman lines being infected because proper support wasn't given. So all of this research led to the development of SCARF. And what we wanted to do was we wanted to learn from research that was done and then put into practice and try to integrate a new pathway to support survivors and reduce readmission rates by improving communication and support, and thereby improving quality of life for patients and carers. Our goals starting the project were to have quicker and better feedback to healthcare providers from the acute setting into the community setting, and to improve community recovery of intensive care survivors. We also had a goal of reducing early unplanned readmissions by 20%. So this is our general pathway that happens for the patient whenever they're admitted into intensive care. My job is to assess all the patients who come into intensive care through an assessment tool, which I will shortly show you. And whenever a patient goes on to our assessment, between myself and our administrator, we will email their GP, we'll find who their pharmacy is. We have made contact with the integrated joint boards within Edinburgh. They are a collection of multidisciplinary team members based in the community, and we will speak to the family. And we will alert the health professionals that this high-risk, complex patient has been admitted into intensive care, and there is a high chance that their care outcomes will have changed upon discharge. Whenever the patient is then discharged to the ward, I go and visit the patient, introduce myself, as well as giving some basic information about things they might experience post-discharge from intensive care. And that is learning from the PICS syndrome that patients might experience different systems, as well as giving support, but also trying to find what their social engagement is like. What support do they have in place, and what extra support might they need whenever they go home. Then, whenever the patient is discharged, we email the GP, the pharmacist and the hub a shortened summary of the patient's stay in hospital and intensive care. And on top of that, to the hub, we will give a breakdown of any additional needs we think that this patient might require going forward, and if they're able to meet that. Aside from that, on discharge, we also try to support the family member going home. We offer third sector support and try to signpost to maybe counselling or other areas of support that the family member might find. In 2 and 8 weeks post-discharge, we do a follow-up with the patient where we call them to see how they're getting on at home and if they require any extra support. And it has been known that on the back of that, I've contacted the hubs again requesting extra support for the patient to try and keep them at home so that they're not readmitted back into hospital. So this is the assessment tool that we're using at the moment. And what we're trying to do is learn from the 10 key areas that we saw with patients earlier. And so we want to see if they had multiple admissions within the last 12 months. We wanted to see if they had more than 4 comorbidities, creating a complex patient. We wanted to see if they had polypharmacy issues, if they had a history of mental health, substance misuse, were concurrently on antidepressants or psychiatric medication, if they required additional significant help for activities of daily living pre-admission, if they live alone, and what their general demographic is. And all this information we want to know prior to admission to hospital, not what happened in intensive care, which creates a different pathway. What we generally found actually was that our patient group met 2 different kinds of cohorts. We had our complex medical patients who were comorbid and polypharmacy, and then we also had our mental health patients who generally had history of mental health, substance misuse, and were on complex antidepressants. So the impact that we have found as a result of this has been multifold. We've had patient has felt more supported, they felt heard and understood as a result of conversations. Often having that simple conversation with a patient post-ICU helps them to realise that the symptoms that they're experiencing are normal, and that is also through the use of the discharge sheet that we've provided. And part of my job has been to signpost to counselling or to our intensive care support group that we have running for patients, which is called ICU Steps. For family, they feel seen and heard. We had a situation where a brother was really concerned about his brother and was able to give us information, which meant that the patient was retained in hospital for longer because it exposed a really extreme social circumstance which would have led to a readmission. As well as system impact. As a result of this study, we've realised the incredible need for counselling for not just patients but for family, and we have begun to integrate a counselling service for the entire intensive care department for patients, relatives and staff to try and support people better through the intensive care experience. So progress to date has been that we are 10 months into the project. We have had 235 patients. Our PDSA cycle has revealed that we have a very high percentage of substance misuse and serious mental health patients that accumulate approximately 30% of our cohort. And these patients are incredibly hard to follow up. And an interesting finding was that changed the pathway of our project. So we had to create a separate pathway for these patients as they were proving incredibly complex. Our assessment tool is identifying the patients who are readmitting back into hospital, which is a really encouraging sign. We have made contact with 14 hubs, 7 integrated healthcare hubs and 7 mental health and substance misuse hubs. Our provisional reports have shown that through this project we have reduced readmissions by 10%. And our next step going forward is that we will be looking for an NIHR grant for a larger scale intervention within the southeast of Scotland. I'd like to say a special thanks to Health Improvement Scotland for funding this project. Eddie Donachie was our project manager, Dr. James Marple was our clinical lead, and Julie Fenton was our administrator. Many thanks for listening.
Thank you so much, Jo, on behalf of everyone in the room and those that are joining us through the live stream. I have a question for you, and then I'd like to open up to the audience to see if anybody else would like to ask anything of Jo. Given that you have such a unique role, from clinical practice to research, and now meeting individually with the patients and their families, what are you most proud of?
I think I'm most proud of being able to impact the patient as an individual on their journey and realising for the patient that they're more than a system, that they have complex needs within them, and being able to meet those needs for the individual so that they feel seen and heard, and hopefully the plan for keeping them home and reducing readmissions, I think, is something that has impacted me the most.
Isn't that amazing? When we talk about integrated care, we talk about it ultimately from the perspective and experience of people and their families, so that people and their families experience multiple part of our health systems and the people in it paying attention to what's most important to them and helping link our different parts of our health system from the ICU to the community to primary care together, and it sounds like that's what you're doing, and you get to do it directly with people and their families, so congratulations. I think that's great. What about for anyone in the audience? Do you have any questions, thoughts, and reactions for Jo? And she'll also be available, I'm sure, after. Okay, thank you so much, Jo.